Good evening, everybody. Welcome to ProMed's webinar on patient clinical report forms. My name is Matt. I'm the Managing Director of ProMed. Just going to give everybody another minute to get themselves settled. I can see we have a huge range of people tonight and people still joining us. Thanks for letting me know the sound's okay. Really pleased to see so many people. So I'm just going to give everybody another few seconds just to make sure they've got a notepad and pen, get themselves nice and comfortable, and then we shall start the webinar in about 30 seconds time. Okay, good evening, ladies and gentlemen. My name is Matt. I'm the Managing Director of Professional Medical Ambulance Services Limited, bringing you tonight's webinar on filling out patient clinical report forms correctly. I'm a qualified teacher with PGCE. I've completed a major incident medical management and support qualification. Clinically, I am a first response emergency care level 4, and I also have a BSc honours degree in biomedical sciences, which I've held for 8 years. I've worked in events, crowd safety, security, event safety, medical since 2006. I have authored various event, crowd and medical operational safety plans for events from 50 to 280,000 guests. And in terms of patient clinical record forms, I'm in the middle of redesigning them for ProMed. I also audit the ones that ProMed has when they come back from events to make sure they're complete and accurate and are meeting the needs for our insurers and for our business. Really pleased to see we've got so many doctors, medical students, nurses, emergency department staff, pre-hospital staff, student paramedics, school first aiders, whole range of people, pharmacists. So it's really pleased to see everybody introducing themselves tonight. Please do feel free to share your social media details. So ProMed is providing these courses completely free of charge. We just want to increase the awareness of the different aspects of the operations and logistics behind providing pre-hospital healthcare. But in addition to that, we do also offer face-to-face paid training courses. They're all available on our website, which is www.promed999.co.uk/training for full details and dates. But just to give you a little taster, we do the FREC 3. We also include the Level 3 award in administering medical gases, which allows you to use Entonox when you're working under the scope of an appropriate company and practitioner. That's £390, including VAT. We have a level 4 certificate in first response emergency care. That's £475. We do have one of those courses which starts this weekend. That one's full, so the next one will be in 8 weeks' time. Our FREC 3 is the 24th of October, running over 3 consecutive weekends. So it's Saturday, Sunday, and then just the Saturday. If you need to requalify on immediate life support, so however you obtained your immediate life support, whether you've done your FREC 4 or whether it's for your professional registration, we do offer the annual requalification there. That's £150, and we do include a copy of the latest Resource Council UK guidelines. And we also do the safe administration of life-saving medication course if you work for a CQC registered provider. That's £200 for the 2-day course, next one running on the 21st of November, and that includes a JR Calc pocketbook. If you are interested in any of those, do visit our website or just email training@promed999.co.uk to book onto those courses. I would love to welcome you onto any of those when you're free. Just to make you aware, I can see quite a lot of new faces tonight. We are now at capacity, which is exciting. Everybody here has the right to attend our events with a space free from bullying, intimidation and harassment. You've got the right to be treated with dignity, respect and courtesy and not to be discriminated against. That obviously means you're also responsible for treating everybody with dignity, respect, courtesy and not discriminating. Our full code of conduct is on our website there. And if you do need to report any inappropriate behaviour, just privately message our admin team, or if you need to email webinars@promed999.co.uk afterwards, that's absolutely fine. admin teams just posting our links in there. So we will encourage healthy discussion, debate. We will see differing opinions. I will kind of vocalize quite a lot of those. That's absolutely fine. You know, this is how we learn from one another, by having those discussions. As long as they're respectful and appropriate and safe, that's absolutely fine. So tonight we're going to be looking at a few aspects. So like many things, we're going to start off by looking at the underpinning laws, what in the UK governs the patient clinical record forms, why do we need to have them, who has the right to access them, why do we have to write things down. We're going to look at a minimum identifying data set. So how do we know who that form applies to? How can we be sure it is for this patient? We're going to look at what did you do? And why did you do it? So the salient things that need to be recorded on the form are what you're doing and why you're doing it. Did you check everything? What has actually happened to your patient? And then finally, we're going to look over the data security aspect. So if we're going to be creating this piece of paper or creating this electronic document, we need to make sure that we are protecting the security of that data. So our underpinning laws start with the Access to Health Records Act in 1990, and this is what allows access to a deceased person's records. So obviously we will create records about living people, because as pre-hospital care providers, our intention is to keep people alive, at least until we get them to the hospital. However, with the best will in the world, unfortunately, some of our patients won't make it. They will pass away. And their families, their loved ones may have a right to access those records. That may just be because they want to know what happened in their final minutes. It may be because of pending legal action. It may be that they're concerned that their relative was mistreated. So there are certain circumstances when those responsible for the estate or the next of kin can have access to their health records. And we need to bear that in mind. You know, if we're doing things like a roll form, so recognition of life extinct, that we need to be, you know, very careful in our language, and certainly be mindful of the fact that the person who's reading this could well be, you know, the wife, the husband, the son, the daughter, the mother, the father of this this patient. So we need to be quite considerate in our language. We need to be very mindful that, you know, would we want our mum to read this about us? You know, that's a test I always apply when I talk about another person. If my mum was reading this about me, or if I was reading this about my mum, would I be happy with that? And that's a fairly good test to use in a lot of circumstances, in terms of talking to the patients, in terms of carrying out a procedure, a treatment. You know, would I be happy if I saw someone doing this to my mum? Would I be happy if I heard somebody talking like this to my mum? If not, then I wouldn't do it myself, if I'm perfectly honest. I always have that in the back of my mind. We then have the Medical Reports Act of 1998, and that gives the rights of individuals access to any reports relating to themselves provided by any medical practitioner for any employment or insurance purposes. So in regards to what we do at ProMed, we will quite often treat people who are deemed for whatever reason to be employed. We provide medical cover to film and TV sets. We provide medical cover to events. In both of those areas, we have persons who are deemed to be employed. And if they have an accident, sustain an injury, contract a certain disease at work, then we are legally obliged to ensure that an accident report form is completed. So anybody working for ProMed, they are legally obliged to complete an accident form for ProMed. However, if they don't work for us, we have to ensure that they complete that paperwork with an appropriate person, their employer, and those records they have access to. Likewise, for insurance purposes, so if we are carrying out a medical on behalf of somebody in terms of can they participate, can they do this job, you know, or afterwards, you know, our insurer wants this because they have a legal basis to access that. So, you know, look at the Medical Reports Act, find out what circumstances. But actually, there are many quicker and easier ways as to how a patient can get a hold of their own records. This just is very specific where money is changing hands, there is specific protections in place. We then have the Mental Capacity Act of 2005. This looks at the capacity to give consent at a specific moment in time. And whilst there aren't necessarily direct application of this to patient clinical record forms, we need to be able to say with certainty after the fact that we knew a patient had capacity and that we obtained consent from them. So it's no use if you are questioned in a court of law 4, 5, 6, 7 years down the line, and you're going, yeah, well, I always ask everyone, if they're happy with me doing it. Well, that doesn't prove you did. So, how did you assess that patient's capacity? What basis did you have for thinking that they were oriented to time, person, and place? How did you know that they understood the information you were providing them and could retain that for long enough to make a decision that was in their own best interests? If not, what steps did you take? What options did you consider to be sure that you were acting in their best interests? So Mental Capacity Act is applicable more so to our clinical practice, to our treatment, to our interaction with the patient. But we need to make sure that when we're writing up our documentation, we don't overlook what may seem to be quite obvious. A lot of people just assume that consent is there, and that's not always the case. And if we ever are to account for our actions, we need to be documenting how we're assessing these things, how we're coming to these conclusions. There is the Equality Act 2010, and that means that we provide equal treatment regardless of any protected characteristics. So particularly in terms of patient clinical records, one of the main things is we need to ensure that everybody has access to their records. Now, it may be that they struggle to read, and a reasonable adjustment would be that we could sit with them with their form and read it out for them, or we could provide it to an alternative person that they've named who is a reader for them. Maybe that they are visually impaired and need high contrast. It may be that they need it to be provided in large print or on Braille. It may be that they find reading things difficult on paper and they would prefer an electronic copy that they can use with their own assistive technology. And there are reasonable adjustments that we could make to allow somebody to access their own records. Likewise, as we're writing stuff down, we need to be mindful that not everybody is comfortable reading. So if we're providing them with a copy of our treatment provided straight after we've done, which is a very, very good practice, certainly a best practice, I would say. If they perhaps have dyslexia, if they have that visual impairment, if they have a learning difficulty, how are we sure that they have the same access to their record that we have perhaps assumed they would have? Have we spoken to them? Have we actually said, I'm going to leave you with a copy. Are you happy with this? Can you read this? Do you want me to explain anything to you? Sometimes we might have used some technical words on there that they might not understand. And, certainly by way of disability, we need to ensure that they have access just the same as anybody else. Other things that might be protected include pregnancy, include gender. So if we've recorded that information, we need to be aware that obviously that's a personal characteristic about someone, but we also need to make sure that when we're documenting this, how have we documented it? Does it look like we have treated that person differently overall by way of a protected characteristic? Have I treated somebody differently with a chest injury just because they're a man than if they're a woman? Have I treated somebody with a lower leg injury differently just because they were pregnant? Have I treated somebody differently with a simple cut on their hand just because they are young or just because they are old? If I have, or if it comes across that way, then that's going to cause us some issues in the Equality Act. So we need to make sure that when we're documenting things, we're documenting our rationale, and we need to make sure that how we document that rationale is coming across that we are doing it purely based on that patient's presenting condition and that patient's medical conditions or that patient's capacity that has affected how we have provided the treatment, and not because of any other characteristic. Because ultimately, as practitioners, whether we are a basic first aider, whether we are a registered healthcare professional, or somewhere in the middle of that spectrum, our role is to provide the best possible care within our scope of practice, purely based on that patient's presenting condition and their medical conditions and what capacity they have at that moment that we are treating them. We don't care for creed, colour, religion, race, money, societal background, or anything like that. We simply care about providing that treatment to that patient at the moment they need it. The Health and Social Care Act 2012 provides a lot of information about recording interactions with patients where we are providing treatment, where we're providing social care, where essentially we take on a duty of care, however we kind of loosely term duty of care. Where that exists, then there needs to be records kept about how that care was provided, the quality of care that was provided, and there needs to be a robust framework in place to ensure that the care met the appropriate standards and was legal. The Human Medicines Regulations 2012 places duties on prescribers and persons who have authority to administer and persons supplying those medications. So registered healthcare professionals, certainly a doctor, can prescribe any drug. However, that prescription is valid verbally. However, it's best practice to record that prescription. It doesn't have to be on an FP10. It doesn't have to be on anything with a doctor's handwriting, but that prescription should be recorded somewhere. We should know what drug was given to that patient and on whose orders. If it's controlled drugs, then we need to ensure that that drug is absolutely traced from its secure storage into the patient or how the rest of that drug was disposed of. So if I've drawn up, and I wouldn't, not being a healthcare professional who has a legal basis, but if a healthcare professional has drawn up 10 milligrams of morphine, because that is your standard ampule dose, but has only administered 8 milligrams to the patient, where's the 2 milligrams? It seems trivial, but there is a legal requirement to record the destruction of those controlled drugs. So it may be as simple as a line on the PCR, remaining morphine put into denaturing pot after patient treatment concluded. There we go. We now know what's happened because that morphine was ultimately drawn out of the safe to be issued to that patient. So we need to make sure that our human medicine regulations, recording and prescribing is being complied with. And then there is the General Data Protection Regulations 2017. Now this gives living individuals certain rights, and it gives responsibilities to those who are processing and storing or using that data. So we need to ensure that living individuals have access to any records, any data where they are identifiable. We need to make sure that we are keeping it safe and secure, that we are only using it for the lawful purposes, that we are only processing that where consent exists. So our data subjects or patients have the right to choose whether we process their data or not, and they need to be aware of how we're going to process that data. So again, it's not just a case of filling in the form, sitting there with them. We need to actually say to them, I'm recording the information about our interaction as a record of our treatment. This is going to be kept secure. It will be passed to our head office. It will be recorded on our electronic database. Are you happy for us to do that? And we should be recording whether they are or are not happy for that to happen. We do have a legal basis argument in terms of the Health and Social Care Act 2012, in terms of the Human Medicine Regulations 2012, to store and process that data to a limited extent, but it is much more preferable to obtain that consent, and it is absolutely essential that the data subject is still informed what we're doing, regardless of whether they consent or not. So let's now look into the nitty-gritty of actually creating our PCRs. So, of course, part of the minimum identifying data set is going to be the patient's first name. What are we calling them? And this isn't always possible to obtain in an unresponsive person, but we can perhaps ask their friends, you know, who is this? You know, are they legit? Can we, you know, is this definitely them? Do we have any kind of identification? Do we have a driving license, passport, biometric ID card? Do we have anything on them that we can use to confirm who they are? Same for surname, same conditions apply there. But again, it's part of that minimum identifying data set, as is that patient's date of birth and their locality. So with those 4 pieces of information, certainly within the UK, we can, with a great deal of certainty, not 100%, but with a great deal of certainty, we can link the record to the patient. So by using that information, we can say that's them. Now, it may be that we have our own internal identifiers. It may be that a hospital has an identifier, and we should include that on all records belonging to that patient. So any town hospital, NHS trust, unique patient number 123456778. That allows that patient to be uniquely identified within that trust. That record number should be on every document that is produced by that trust. And that allows those records to absolutely be tied to the right patient. If we can't get that identifying data set, we should write down as much information as possible to reduce the error of those records not being reconciled against that patient. So how old do we think the patient is? What skin color are they? What gender are they? Where did we find them? What clothes were they wearing at the time? What's their hair color? What's their eye color? Did we notice any tattoos or birthmarks or identifying features of their body? What is their build? Anything about them that we can use to link that patient to that record until such a time we can get this minimum identifying data set in place. Hopefully at some point this patient will regain consciousness and we will be able to obtain this information. But what if that patient is later deceased before we've identified, from them who they are? How are we going to ensure that their records stay with them? What if their records get dropped and somebody is trying to figure out who they belong to? Have we provided enough information for that to be able to happen? So the main purpose of our patient collecting records is actually to record what did we do. So the first thing that we do for every patient we encounter is a primary survey. And this needs to be recorded. Now, depending on your setting, if you work on a medical ward, if you only do routine operations, if you're on a first aid post and the patient walks up to you, if you're on a film set and somebody pops in and says hi, your primary survey is kind of done in the back of your head. It's not really something you've formally considered. Well, they're standing up and talking, and they're talking in complete sentences and they are coherent. So by default, I've just said they've got a clear airway, they're breathing normally, they are well perfused, and they are not showing any abnormal disability features. However, have I documented that? Where on my paperwork have I said that from the outset of this interaction, this patient was not showing any life-threatening concerns, hence why I sat down and have a chat with them? So what interventions have we done? So have we used an airway? Have we inserted an IV? Have we repositioned them onto their side? Did we choose to use an orthopedic stretcher? Did we get a wheelchair for them? Did we help them take a seat in the first aid post? Did we get the ramp down on the ambulance? Did we shine a light in their eyes? What interventions have we done to that patient? What drugs have we gave that patient? Have we gave them 2 paracetamol to take? Have we gave them a 500 ml bag of saline? Have we gave them 25 grams of 40% glucose gel? Did we give them some Calpol? Have we opened a cylinder of oxygen and gave them a specific litre or a specific fixed inspired concentration of oxygen? Have we gave them nitrous oxide? All of those are drugs that we have provided that patient. What about the other treatments? So did we dress their wounds? Did we clean their wounds? Did we get some running water for that burn? Did we use burn gel? What other treatments have we provided? Did we sit with them and listen to them while they were offloading about something that is affecting their mental health? Did we find them in a dangerous place and we have talked them down? Did we find them with a knife having self-harmed? And have we therefore sat with them and removed the knife from them? That is all a treatment that we have provided. It may not be the same as cutting somebody open and inserting, various devices into their body, but mental health treatments are still a form of treatment that we need to be recording. What about referrals and consultations? So during our treatment, did we consult with anybody else? Who did we consult with? What time did we consult with them? If they called us back, what time did they call us back? Did we make a referral? Did we ring their GP? Did we speak to the Falls team? Have we spoke to their employer, or had we spoken to the health and safety department about them? And what were they referred for? How urgent was that referral? And what are we expecting in terms of follow-up? But then we have to justify what we did. So, what did we do also includes examinations. So I fully exposed the patient from head to toe, checking for any injuries. Is that justified if patient came in with a paper cut on the finger? Look at me, I'm a 30-year-old male, and my 15-year-old female patient comes in with a paper cut to a finger. And if I write on the patient report form, exposed patient top to toe to check for other injuries, is that justified, do we think? It's absolutely not justified, of course. So what about the trauma patient? What about the 20-year-old female who's been in an RTC and we've came across them, they're semi-conscious. What about if I then write, I have exposed them from head to toe to check for additional injuries? Is that justified? Yes, it is. Because in those circumstances, if they can't communicate to us about their injuries, and there is a mechanism of injury to support the fact they may have hidden injuries, then there is a necessity to carry out that examination. So what basis are we intervening? What basis are we examining? What basis are we providing treatment? What basis did we give the drug? So first of all, we need to know the patient's presenting complaint. So am I going to ask about a patient's genitourinary habits if they are complaining of a cut finger? No, I'm not. But let's look at our differential diagnosis. So our patients come in with lower right-sided abdominal pain. So there's quite a few things I would need to ask about and examine. I would want to ask about urinary habits. I would want to ask about bowel habits. I would want to consider the type of work they do, any physical exertion, exercise they do, how they travel. Because that's justified. I would also be justified palpating the abdomen, the groin, the lower back, because all of those areas could be referred pain. So what are my differential diagnoses? What am I working towards? What am I trying to rule out? And does that justify why I did what I did? What injuries did I find? Okay, I found a small incision on the front of the body. Okay, that then justifies me perhaps doing a log roll, even if I suspect a spinal injury, because they may have a more severe wound on their back. So think about everything that we found. The other reason we're documenting injuries found, of course, is if we neatly package that patient, what we don't want to be doing is unpackaging them for the sole purpose of a repeat examination. So if I found injuries, I want to record them so that when I hand over my care, I don't forget to mention them, and so that the next care provider is aware that those injuries are there, and they don't need to unpackage a patient just to find out something that we already knew an hour earlier. It also means that we can account for everything and we can ensure that that patient gets the full quality of treatment. We need to remember, of course, that injuries aren't just physical injuries, but they're also mental injuries, things that affect well-being. So patient presented with, let's say, I don't know, patient presented having tripped over with a swollen ankle. talking to the patient and they highlighted that they have not been eating well for the last 2 weeks. That should be documented because that is something that a next care provider is able to treat. We're probably not as a first aid or a first response team or even an emergency medical technician, but a primary care provider or a mental health provider, it is within their remit. And unless we're documenting that we found this information out, how do we know that the next person is going to find that information out? We can't assume that that information is going to be passed on unless we've documented it. We need to ensure that we document that we have thoroughly evaluated cautions and contraindications. So this is something that I see quite a lot of when I'm doing audit. And it will be, really simple, really obvious things. Gait Emptonox for, wrist fracture. Great, lovely. And I'll read through in lots of detail. And there's no mention of bowel habits. No mention of last eating and drinking. Okay. Did you check for any trapped air? Well, yeah, I asked the question. Well, not according to that paperwork, you didn't. I've got a headache. Can I have a couple of paracetamol? Yeah, you taking any in the last 4 hours? No. Yeah, perfect, of course you can. And you'll read the PCR, and it'll be, primary presenting complaint, headache, OBS, none, treatment, paracetamol provided, drugs, paracetamol, 1 gram, PO, signed. And that'll be it. And like, okay, have we checked if the patient's allergic to paracetamol? Have we checked if they've taken any paracetamol? All those considerations haven't been documented. So we need to be sure. So we need to, if we're giving anything, if we're doing anything, what did we check for cautions, contraindications? Is it obvious if we read our document without knowing what happened at the incident? Is it obvious that we made the correct decision? Is it obvious that we went through the motions? So I always get my JR Calc out and I always look through and I always go, yep, I'm going to give it an ox. Right, have we got this? Have we got that? Have we got the other? No. Right, let's look at my PCR. Is this documented? No. Right, okay, so let's ask my patient just to confirm. You haven't got this, you haven't got that, you didn't have an injection in your eye. No, okay. Blah, blah, blah. And I'll write that down on my piece of paper because that is what is proving that I did do that check. It's no good saying, yeah, I always check, because that doesn't prove you did that check. What if it was the one time you thought you checked, but you didn't? How does anybody prove what did or didn't happen if you've not documented that somehow? Observations before and after, really important. It's amazing how many pieces of paper that I see where we see SATs of 91%, oxygen 15 litres, and you will then not see another SATs recorded on that PCR, despite the fact the patient was in your care for 45 minutes. Oh, yeah, the oxygen went up, that's why I let them go home. Right, okay. Where does it say that? Well, it says I discharged them. Right. Taking the oxygen with them? Well, no, obviously not. Well, it doesn't say that though. It says you gave them oxygen at 15 litres. It doesn't say that their SATs improved. So whatever we are doing, whatever interventions we make, we need to assess whether that observation has improved that patient's condition, made the patient's condition worse, or kept them stable. Now, depending on the intervention, keeping them stable might be in the aim. But actually, if it's not improved the patient, what have we done it for? Why do we still need to keep doing it? If it has improved, we need to make sure we're documenting that the patient's condition is now improved for the better, i.e. our presence was worthwhile. So did we actually check everything? So a lot of PCRs have lots of boxes, lots of things to tick. They're in a particular order. They've got particular prompts written all over them. And that's to make sure that we don't miss anything. So when we're doing a secondary survey, we need to go through samples. So did we ask the patient about their symptoms? Did we look for signs of injuries? Have we asked the patient what allergies they've got? Have we asked them what their medical history is. Have we asked them what current medications they take? What about their last intakes and outputs? Did we check for everything else? Have we considered their environment? If they've told us they're in pain, did we run through Socrates? You know, have we done this? Have we actually exploited all of the information? Or have we just got focused on the presenting complaint or a distracting injury to miss something? Well, if we've just wrote down the presenting complaint, and if we've just wrote down the treatment of the presenting complaint, what we've not done is we've not shown that we have done a meaningful assessment. We've not shown that we have actually considered what else could be going on. We've not shown that we were diligent in our job, we were doing our job properly. So when we assess the patient, have we followed the medical model? So if they've been telling us about their back pain, did we ask about their kidneys? Did we ask about their cardiac issues? Have we considered that it might be an aneurysm? Have we gone through each body system and reviewed it? Have we asked about their social history? Have we asked about their previous drug history? Have we asked when they last saw their GP? If it is a trauma situation, if it is something that quite often happens in first aid, in events, yeah, I fell over. Fell over on what? Oh, yeah, just, I was just walking on the ground and I tripped. Okay, yeah. Did you fall onto the tarmac? Did you fall onto the grass? Did you fall onto the other piece of barrier? What did you actually fall onto? Oh yeah, I was up the ladder and it gave way and I fell off. Okay, where were you stood on the ladder? How tall was the ladder? What were you holding on to? So the mechanisms of injury there, quite important because they are very suggestive of any further injuries. And if we're not recording that, how does the next person know what they should be looking for, what they should be alert to? Same with RTCs. I've attended several off duty, and I know some of my colleagues have. And, you know, depending on who we're working with, sometimes we will be getting information from people, and it's, yeah, passenger in an RTC. Great. Were they in the front? Were they in the rear? Were they wearing a seatbelt? What speed were they traveling? From which direction was their vehicle hit? Did the airbags deploy? All of those pieces of information alter the risk of injury profile to that particular person. So if we've not recorded the mechanism of injury correctly, we don't know that. Also consider the mechanisms of acute illness. So if somebody is having an MI, what mechanism caused the MI? Which H or which T caused it? Did we consider all of the H's? Did we consider all of the T's? Have we documented, you know, considered, you know, patient temperature? Right, there you go, there's hypothermia covered. In the field, we can't do hypo or hyperkalemia. We can do hypoglycemia. We've done a BM, perfect, tick. Toxins, bit difficult to do, but no evidence of intoxication. Great. Tension pneumo, no evidence of, you know, chest sounds good, no tracheal deviation, no JVD, etc., etc. So have we actually considered what has caused the patient to be acutely ill? If we're getting a news 2, 7 or higher, and, you know, we are suspicious that there is an infection, have we considered what is causing that infection? Can we smell a UTI? Can we see a wound that is infected? As the patient told us, they've got a blinding headache and can't stand the light. What is causing that sepsis? So we need to be very mindful of what has caused that. AS, a very good question. So SAMPLE stands for signs and symptoms, allergies, medications, past medical history, last intake and output, and then everything else or environment. And it's a structured way of making sure that you don't miss the important questions when you're talking to your patient. And then we need to look at consent. So did we have the patient's consent to assess them? Did we have their consent to treat them? If we did Do we know that patient had capacity? Excuse me. Not more good. Did we confirm that they are oriented to time, place, and person? What information did we provide them to be able to make their own decision? How did we check that that information had been retained for long enough for them to make their decision? Were they assisted by anybody to make that decision? If they're a minor, what consent did they give and what consent did their appropriate adult give? Have we acted in loco parentis? Have we acted in their best interests? Has this been documented somewhere? So I dislike the boxes that say at this time the patient has capacity to consent, or at this time the patient does not have capacity to consent. Well, they might have the capacity to consent to an immediate life-saving treatment, but they might not have the capacity to consent to paracetamol. So consent is dependent on every individual decision that they're taking, and we need to actually document how we're doing about that. So it's no good writing down in treatment notes 2 times paracetamol, consented, yes. Advised paracetamol can treat headache. Advised may also cause. Or provided patient information leaflet, which patient read and confirmed they understood by whatever. And then we need to know what has happened to our patient. So we've provided care. We provided a period of care to this patient. Sometimes that may have resulted in that patient passing away. Sometimes that may have resulted in that patient being in an emergency ambulance. Sometimes it may have resulted in that patient being handed over to the doctors and nurses at a receiving hospital. Sometimes that patient may have gone back to the event or the film set or their place of work. Sometimes they may have gone home in the care of a responsible and capable adult. We need to document where they went and on what basis we came to the decision. If we concluded their treatment, which clinician decided their treatment was concluded? If we've sent them somewhere, what advice did we provide? So quite often, our lower grades of staff will indeed treat cut fingers, will indeed treat simple sprains where the patient can very clearly weight bear and has full range of movement and has the appropriate pulses and is not complaining of anything untoward. There is no immediate discoloration, there is no obvious deformity, and all the checks have been done to the nth degree. But that patient's treatment is not concluded because a first response grade member of staff is not somebody who can discharge patients. They cannot conclude treatment. So what advice did they give them? So at ProMed, we have some standard worsening advice leaflets, some standard kind of self-care guidance leaflets, and we would provide that and we would document, you know, standard blah 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 you know, leaflet given, version whatever. We also have patients sign that slip so that we know that they have acknowledged the receipt of it, and that will advise them what to do. So, you know, head injury, if you get dizziness, if you get blurred vision, or you know, give it to a friend, you know, if you notice this person is confused, take them to hospital, call 999 for an ambulance. So what advice did we give them if they feel they are not improving, if they feel they are worsening? Have we told them to make an appointment with their GP to be followed up because they're telling us this was the second time they've passed out in a month? Have we, you know, advised them to speak to their parents because they're 14 years old and they should probably tell their mum? We can't force them to, of course. We can't tell their mum for them, but we can certainly advise them to. And we documented that's what we've told them to do. Where did they actually go? So I've outlined a number of options there. And how did they get there? So did they go to hospital in an ambulance under emergency conditions? Did they get sent to the minor injuries unit with their friend in the back of a taxi? Did their employer give them a lift home? So where did they go and how did they get there? Who did they go with? So if we're not convinced that they are able to care for themselves for a sufficient period of time, If we don't believe they have capacity, if they are a minor, if they are clearly under the influence and not looking after themselves, have we ensured that a responsible, sober adult is with them? What did we say to that responsible, sober adult? Is that documented anywhere? What time did our care end? So the treatment might not necessarily be concluded, and we provided that advice, but what time did our care end? What time did they physically separate from us? And then if we do a clinical handover, to whom did we do that clinical handover? What is their name? What is their registration or their grade or their role? At what time did that handover commence? What location did we do that handover? Was it the first aid post and it was the foot patrol team handing over to the nurse? Was it the ambulance crew handing over to the admitting sister? Was it a doctor handing over to a consultant? Were we doing this in a first aid post? Were we doing this on a hospital ward? Were we doing this at the front door of the hospital? And what was the patient's condition at the time of that handover? So had they improved? Had they deteriorated? Were they conscious? Were they unconscious? Were they deteriorating? Were they currently on any drugs, medications, oxygen at the time we handed over? So what condition were they in? And then lastly, let's look at the data security aspect. So if we have electronic data, has it been encrypted? Who has access? How are we ensuring that it is only that person using those credentials? What location is it being stored in? How is it being transferred to and from that location? So if we take the simple one of, well, I've got a username and password, okay, great. But actually, I think my nana might know my password because actually it's my mum's maiden name, or it's, you know, the street I used to live on when I was a child. Well, that's not really a strong password to begin with, but how have we ensured that? So do we use things like two-factor authentication to prove that not only do you need to know the username and password, but you also need to be in possession of the device that's linked to the account? If the data is being transmitted over the internet, and I know a lot of providers use cloud services, is it over HTTPS? If it is through a web browser, are there other protocols in play that ensures that that data transfer is secure? What is in place to ensure that the complete document has arrived and that it hasn't been interrupted? All of those things need to be factored in. It's also no use having things stored electronically on a laptop with password protection if you never actually lock your laptop. If you nip away to the toilet and then on the way back you go and make a brew and your laptop's just been left out on the first aid post desk, and then Joe Public walks in or security pops in and decides to have a nosy to see if any of their mates have been in. And in terms of physical, we need to be sure that what we're recording is visible. So this is from the moment we actually start putting pen to paper, really. Who can see what we're doing? If we're writing stuff down, are we leaving that on the side? Are we writing stuff down? Are we having a really whispered conversation with a patient about a sensitive personal issue? But actually, the guy who stood over us from security can just look down and read everything we're writing. Well, that's not really the best way of securing that data. If we need to pop the paperwork down so that we can assist somebody be lifted onto a stretcher or handled out of a tight space or whatever it may be, what have we done to ensure that that data is covered up? So I quite often have my metal clipboard has a nice big hole in it, and I have my clips on my belt, and I make sure that I just grab something to stick it on top, and then I clip the board to me, or I put the board, if it's a single-sided document, I put the board with the PCR side against my leg, and that just makes it less visible. It means I am taking that patient's data security simple. We also need to make sure that we don't use what we call multi-use forms. So don't have a table for, plasters given out. Don't have a table for paracetamol given out, because then you're creating records where one patient's records are immediately adjacent to the next patient's records. Who can remember being in a workplace with a good old-fashioned accident book? So, you accidentally cut your finger and, off you go to the office to write down that, you've cut your finger. And while you're there, you're having a good old giggle at, I never knew Johnny fell over and went down the stairs on his arse 3 weeks ago. That's funny, that. Well, actually, it's really not funny. It's a serious breach of data protection regulations, isn't it? And if, Johnny is then the victim of workplace humour, he's got quite good grounds to be suing his workplace because his data hadn't been kept secure. And it's not a laughing matter, really. People's personal injuries and illnesses, it's a private matter, and we as responsible medics, responsible organisations, responsible managers need to be making sure that that data is kept secure. Who has access to it? And this applies to electronic as well as a physical paper copy. Don't leave it lying around in an unlocked room. Don't nip off to go to the toilet and leave all the paperwork lying on the side. I've attended far too many events where you've got, your typical gazebo first aid post, or you've got, your first aid room just off to the side of something. And what do people do? They leave the first aid, they leave the completed forms in an open envelope on the table. Or they leave the completed forms stuffed in a pocket of a bag that doesn't even have a secure tag on it. Or they'll just, leave them on the chair under a blanket. We've all seen this. I'm sure we have all seen this, and it is, it's shocking at best. It's just absolutely shocking. Book bags with ambulance confidential on them is again only good if we are in some way making sure that those bags are secure. Would we know if somebody has accessed that data? Have we got a seal that we can apply to it? If we're leaving a room, can we lock that room? My personal favourite on an event is I usually have a vehicle next to the first aid post, which is kept locked. So it's really easy. I have my open envelope that I'm putting completed records into on the front passenger seat, and I lock the car. So job done. I've completed the record. It is unlock the car, in the envelope, lock the car, job done. It is then secure. People cannot access those completed records anymore. Such simple things, yet so few people seem to do it. On larger events, completed records are quite often ferried up to the control room, because the control room is already a secure environment, and it allows the administration team to do the data entry on them straight away. There is a legitimate need for those people doing data entry to have access to those records because they are processing for the purpose of storing. It may be that once they've been scanned in, the paper records get shredded, and that's absolutely fine as long as that shredding is to a sufficient grade, i.e. the square cutting, not just the line cutting. Are we making sure that those records are being kept secure? Are they being disposed of securely? So personally with ProMed, we don't retain paper records. Once they've been scanned and they've been saved and encrypted, and we have confirmed that we can access them from another device and they are intact, it is at that point we will cross-cut shred that original document, because it is then one less thing we have to control access to. It is one less thing that can go missing. It is one less thing that can go secure. So thank you very much for attending this session. So I'm hoping that by listening to this and by participating, you now have a greater awareness of the underpinning laws for recording patient clinical records on particular forms. I'm hoping that you now understand what our minimum identifying data sets are, that you need to record what you did and why you did it, and it's important to ensure that you check everything. It's very important to know that what has happened to the patient at the end of your encounter, and also that you understand the basis behind data security. Now I'm just going to give you one more little anecdote, and this is the one that came from a little spot audit that I was doing. I was managing an event, and I was just reading through some of the PCRs that came in just to make sure that the quality of care being provided at the time was to the high standard that ProMed expects. And a healthcare professional had an encounter with a patient. They had some sort of injury to their finger. It wasn't anything serious, just minor, but one of our healthcare professionals was there. They assessed them. And they were good. They did, went through sample properly just to make sure that, there wasn't any kind of circulation issues, wasn't any kind of joint issues, wasn't anything in their history that was going to give them a bit of cause for concern in terms of that patient's worsening advice that they needed to cover off or consider maybe sending them directly somewhere before they let them back to the event. And it was very clear they had gone through that process. Because on there, under medications, they wrote salbutamol inhaler PRN. Excellent. Right, clearly you've gone through sample. Past medical history. And they've wrote the word none. And I went back and I went, this patient, yeah, you've got them down as salbutamol inhaler PRN. Yep, definitely. Great, what was that for? Oh yeah, they're asthmatic. Are they? Yeah, I asked them. Did you? Yeah. Well, why else would they be on a salbutamol inhaler? Well, I don't know, but according to your documentation, you've explicitly stated they don't have a medical condition. And it was the horror when they realised what they've done. But it's really important to remember that patients are not on medication for no reason. If you have asked the patient what medication they are on that medication for a reason. Whatever that medication is, there is a reason. It might be an acute symptom, it might be a chronic symptom, it might be an infection, but whatever medication a patient tells you they are on, there is a reason for that medication, and somewhere on your form you need to have documented that you've asked what that reason is, and therefore you have considered that reason, that medical condition, as part of your overall treatment and discharge plan for that patient. So it depends. Yep. So just to clarify on the legalities of patients having access to their records. There is nothing that says we must provide a patient with a copy of their record there and then at that moment in time. However, if a patient requests that you provide them with their data, then legally under the General Data Protection Regulations, you must provide them, because as a data subject, they can make a subject access request to a specific piece of data or to all data that you hold on that person. That does not have to be on any prescribed form, that does not have to be in writing, but a subject access request means you must furnish that patient with a copy of the data you hold on them. So you shouldn't be going via anybody else, because if you as the data controller hold that information, it is only you who is accountable to the data subject. So you can be subject access requested by a data subject, and you must, without reservation, provide that data to that data subject, because they are the living individual to whom it applies. If you're involving other people in your decision-making process, then you could leave yourself liable if you were ever to refuse. The data controller is the person who is responsible for the collection, the processing, the use or the storage of that data. So as a healthcare provider, ProMed is the data controller for our activities. So if we are recording a patient against the treatment they have received, against where they obtained their injury, we are the data controller, because our staff are operating to our policies, they are following our procedures, we are taking those records away, we are storing those records. That data subject can request from us to have access to their records, and we are obligated to provide them with access to that. So thank you very much to everybody for attending. If you would like CPD certificate from tonight, there is a little bit of a backlog, so I do apologise to those who have been waiting for certificates from the last couple of weeks. We are going to try and get those finished off this weekend. We are having an operations team meeting on Saturday afternoon, so hopefully we will manage to get everything finished off, and we will have those emailed to you this weekend. But if you would like CPD certificate, please email webinars@promed999.co.uk with your full name. We will verify that you were in this session throughout. So if your email is from a different email address to how you've logged on to Zoom tonight, please can you just include the other email address and whatever name you've appeared on Zoom, just so we can quickly reconcile that. We're going to verify that you've left us a review. We'll pop them up in a moment, and then we'll email the digital certificates. Fingers crossed we'll get on top of this, and it'll be within 3 business days this time. So we have provided our webinars free of charge, and we are doing this ultimately not just because we want everybody to get the best possible knowledge and succeed personally and provide the best possible patient care, and that is absolutely one of our aims, but we are also doing this to try and grow awareness of our business, and this is helping us. You know, we are becoming more well known, but we do need constant current reviews to maintain our standing. So if you do leave us a review, we would prefer Trustpilot, Yelp, Google, or Facebook. The links are being shared by ProMed admin team, so you can just click on those. They do also come out in the emails as well. So please do leave us a review on one of those. Please do tell your friends personally if you see them, and share about us on social media. We really do appreciate that. I'm now going to just take some questions. So I can see another one that's just come through. So when dealing with minors, where do we stand about informing the parents when the minor says not to? So this is Victoria Gillick versus one of the GP practice. I cannot remember, but if you just type in Victoria Gillick versus, it comes up in Google. And from this, we have Lord Fraser's inquiry, which gave us the Fraser guidelines. And this is how we would test whether a child is capable of making their own informed decisions and consenting. So if by virtue of a child giving consent, they state that they do not wish for their parents to be informed of the consultation, of the treatment provided, of the choice they made, then if they are Gillick competent, as it is known, if they meet the Fraser guideline tests and are deemed Gillick competent, then we must abide by that decision. If we do not abide by that decision, then we have not honoured that person's wishes. Now, we are responsible for providing treatment to people, and it is that person we are accountable for. Now, yes, with minors, you know, there are some decisions that, you know, it is not appropriate for them to be making, because they, you know, we cannot be certain they fully understand the implications of making a decision for a particular treatment or against a particular treatment, and absolutely we should be involving their parents. But you look at your typical 14-year-old and they probably are capable, for the level of treatment that we are providing in the pre-hospital first response arena, they probably are capable of consenting to that. If they're under 14, then maybe they are, maybe they aren't. But actually, even an 11-year-old is capable of consenting to treatment for a cut finger. They're probably even capable of consenting to treatment for a sprained ankle. And if they say, I don't want my mum to know, then we need to just be absolutely certain that we've checked the capacity. How have we checked that capacity? How have we ensured that they are able to give consent, and record that very thoroughly on our PCR and document it. The key point of tonight's webinar is we need to do our job well, and I'm sure we are all doing our job clinically very well. But the message from tonight is document, document, document. Make sure that whatever we do, absolutely true. So are these processes applicable to accident and emergency cases, or more to the clinic reviews? So these processes are actually applicable to every aspect of healthcare. So whether we are sitting in a very nice, comfortable GP surgery, you know, patients coming in for a pre-booked appointment, then there is going to be some kind of record of that care, and we need to follow that process. Why have we done what have we done? What did we do? Did we take some observations? Have we been sure we've not missed anything? That part of the process happens regardless. If we have an accident and emergency setting, if we have a pre-hospital setting, then we may use a template pro forma, which aids us to make sure that we don't forget things. But we don't have to use a pro forma to create a patient clinical record. It is helpful in certain circumstances, but there are other circumstances where you may wish to do it freehand. So the forms that I'm in the middle of designing for ProMed has a mix of both. It has things that, you know, we absolutely need to make sure that we are checking and documenting, but there is also a lot of freehand space for things like the history of the presenting complaint, for things like the medications, the past medical history, the social history, the treatment that we, you know, the examination and treatment plan, the discharge plan. Is a lot of freehand space because that will vary quite significantly. But in terms of a primary survey, there are some standard boxes for that. In terms of drugs given, there is a standard layout for that because we need to make sure we record certain information there. So that's great. Does anybody else have any questions at all? You can raise your hand and we can unmute you and we can have some dialogue together, have a two-way conversation. Or you can just type your message into the chat. You can send it privately by all means, and we will respond. We'll just read your question out anonymously and respond. Or you can just pop your message quite openly in the chat and start a discussion by chat. So any questions from anybody at all? Thank you very much to everybody who has stayed so far. Really do appreciate the fact you've stayed around for the Q&A. Unless anybody has any questions, then just to remind you how to get your CPC certificate, and that's by emailing webinars@promed999.co.uk with your full name, your name you appeared in Zoom, email address you appeared in Zoom if they are different to what your email address says. We're going to verify that you were in the session throughout by using Zoom's register. We'll verify that you've left us a review on one of the review websites that we're going to mention, and we'll try and get those certificates out to you across the weekend. So it was provided free of charge. So you can leave us a review on Trustpilot, on Yelp, on Google, and on Facebook. The links are all there. Anna, you are very welcome. So it is now 20:07. So just in case anybody wants to go back through the chat and see who was talking, capture any social media links, or if you want to click on any of our links to leave us a review directly, then we're going to leave the chat open until 20:15. So that's 8 minutes for you to click on any links, copy down any information that you want. Prabin, Harry, Aditi, Shinsi, Alexandra, Andrew, Annie, Emmy, Zahir, Farah, Shivarahan, sorry if I got that wrong, Karthik, Christy, Marta, Vebhav, you are all very welcome. Appreciate you all coming along this evening. Priyan, Lisa, T, again, you're all very welcome. Alexander, yes, free but loaded. We do try to pack a lot of information into these hours. The other thing I'm going to say is we did mention obviously some clinical things, but we never really discussed the clinical things. And that's because one of our partners, STC Training Solutions, have some very excellent clinical CPD. If you go to our YouTube channel, which the link is in the chat, you will see the STC Training Solutions webinars are right there on the homepage of our YouTube channel. They're also available on our website, www.promed999.co.uk/training. You will find the STC webinars have been linked. They've covered electrocardiography, they've covered anatomy and physiology, they have covered FREC Workbook 1, they have covered assessment of the child. They've covered a lot of different aspects of clinical practice, and they're continuing to do that on a weekly basis. Their webinar series runs on a Monday evening at 7 p.m. Their events are loaded on ProMed's Facebook page, so just look on our Facebook page and you will find, if you click on events, you will see the STC webinars are listed on there as well. So please do go to them. We would love for you to go to both. Let's have a look. We've seen a few more names pop in there now. Alice, Alexander, Jennifer, Angeliki, Ross, Jeffy, Ing, Nikhil, Amin, Teresa, you are all very welcome. Please do come back next week. Next week, we're looking at radio communications. So if you do work in the pre-hospital arena, whether that's events, film and TV, emergency services, anything at all pre-hospital, we're going to be looking at some radio communications, some hand portable devices, mobile devices, a little bit of a show and tell, a little bit of the processes, the kind of procedures, the phonetic alphabet, the kind of buzzwords or keywords that people use on radios. And we're going to go through that kind of from novice level to kind of intermediate experty level, the different bits and pieces that you need to know to enable you to do your job effectively. So thank you very much for coming once again. Jacqueline, you're very welcome. We'll see you all next Thursday at 7 if we don't see you joining us on the STC webinar on Monday at 7. And enjoy the next 5 minutes if you want to have a read through the chat. And goodbye.